Thank you very much for inviting me, and thank you, Professor Afef, for an excellent lecture. That's more the amount of knowledge and information that you've received in this lecture is really perfect. And I'm trying to share my screen. Uh, yeah, there we are. So thank you so much. That's excellent. And I'm so actually encouraged that you are really having the vision to concentrate on these things. Because in medicine, we are so concerned, especially in neonatology, and I've done this for 20 years in acute neonatology, you are thinking more about survival and the intensity, and that's why you go into intensive care. But to think about holistically about the patient is so good. Thank you, Dr. Marwa, for introducing me. I work in Glasgow, in UK, and I work in Queen Elizabeth University Hospitals and Glasgow Royal Infirmary, which has a Princess Royal Maternity, and I do sessions for older children in a clinic in the community in neurodisability. And over the years, when I started my job in the Royal, I started the neurodevelopmental clinic with physio and speech and language. And over the years, I started seeing that there are babies who came with intraventricular hemorrhage grades 3 and 4, um, one side 4, and they can do better than babies who didn't have any bleeds in the brain, and it make you wonder why. And I did a lot of literature review, and I started looking at these patients, and then I did my postgraduate diploma in neurodisability from Hallam University, and then it gave me the opportunity to do these sessions and see these babies for longer till school age and seeing their problems. And it made me think about these babies. And I had the privilege to be on the NICE guideline for developmental follow-up of children born preterm. And we highlight these points about the importance of school age and preschool assessments for these children is not enough to survive. When I was a trainee in neonatology, I used to think of babies as organs without thinking of them as organs. So I want to intact brain, intact gut, intact chest, but a baby is not just that. We know that there is an impact, as Professor Afaf rightly told us, impact of neonatal intensive care on developmental outcome. These babies are not just cute and small. They are actually under a lot of stress, as we've just heard. And I just want to say that what make a baby or a person is not just his biological and medical status. The psychological and the social status may play a big role in who this individual going to be like. And that's our role. I love this quotation. A good physician treats the disease. The great physician treats the patient who has the disease. We have to think about the holistically about the child, about the patient, and about the family. And um, it doesn't apply only to children born preterm. I follow up children who have congenital heart disease or post ECMO, HIE, and you find there is a lot of similarities between them. We know definitely that babies who had significant congenital heart disease, their brain at term is similar to a baby born at preterm 35 weeks. And both of them, as Dr. Afaf just answered your question, both of them have connection difficulty. We don't talk about periventricular leukomalacia just now, but as the only thing that causes the problem and impact on the brain, because Volpe, who did a lot about neonatal brain and wrote books and did a lot of research, Professor Volpe, who is still alive, he writes now about the micro PVL, or the connections that we don't see. So it's so important to think about the whole patient and what we are trying to do with them. So Professor Afaf mentioned that there is sensory problems in the environment around these children. So what are these problems? There is high noise level. Some you can control. I hope we can, because I'm going to take the points that Professor Afaf said and see how we can convert it, if we can, to practicality and practical steps that we can do to um, a, to improve the outcome. But there are things you can't change in the brain, and there are things you might be able to um, ameliorate and reduce the impact on the brain. There is lack of pleasant touch. Think I was once in the Royal College of Pediatric and Child Health, and we were doing a training sub called Child in Mind, and I was put in a hot seat, and I was asked to imagine myself a baby in an incubator. So I've just admitted a 28-week gestation baby, so I imagined myself this baby in an incubator, and it's so actually insightful to think, what is this baby in an incubator thinking? Who is coming in the incubator to prick me? What am I smelling? What the noise and the voice I am hearing? Why every time the incubator door is open, I am jumping? Why, when my brothers and sister looking at me don't know whether I will survive or not, they look so worried? How my parents feel? That was so insightful. I advise you that if you have sessions together as a group, to try to do this, and it actually make you think about the patient more. Lack of pleasant smells. I want you, as I'm talking, imagine one of the babies you are looking after in the neonatal unit or in intensive care or even in a children ward. One of the babies who are less than 2 years old, and they are sitting there in your ward, how they are feeling, what's around them, what they are exposed to. Lack of visual stimulation, intrusive light levels, and light all the time. There is no dark and light cycle, there is no quiet time. So why is this a problem? Because the baby receive the world around him through their senses. And there are seven senses, as we will see now, that they perceive the world through them. So we know the five senses: your smell, your taste, your sight, your hearing, your touch. And there is also the proprioception, where you are in space, and your vestibular, your movement. And they perceive it through their muscles and joints, through their nerves, the touch, the hot, the cold. And as Professor Afaf just showed us, how this is all is going up to the thalamus and how it's interpreting it. Imagine yourself when you smell something nice and you say, oh, this is like my mom's cooking, and you feel nostalgic and relaxed. So all of these things are is actually a connection between your organic and your sensory centers that interpret these or, organic things happening, like the sense of smell when you smell something that reminds you of something nice, or touch that reminds me of something not nice. So occupational therapists have, one of them designed this based on an occupational therapist in the 80s who talked about sensory processing. And she said that this is a pyramid of learning, and that's what we see. So the base for learning, of course, our central nervous system that Professor Afaf took time to tell us about, and she took her time to tell us about also the stressors and the sensory problems. So tactile, touch, vestibular, movement, proprioception, where you are, awareness of space, taste, hearing, vision, smell. All of this will lead you to have body awareness. Motor planning. If I reach here, will I reach and get the toy? In the first year of life, am I symmetrical, right or left, or I am skewed? Postural security. Am I left in space, don't know where I am, or I am contained and organized? And then that will take you to the higher function. And we heard about pruning. And Professor Afaf said that pruning at 3 years of age is so important when we get rid of the synaptic connections and the extra connections that we don't use. But what if you get rid of ones that are essential, but you haven't used it? It's use it or lose it. So pruning is a good thing because that's where we find dexterity. When the child will become right-handed or left-handed, that's as a result of pruning. So it is important, but it can be negatively detrimental to the baby if we are not using certain connections that we are needing. And that's what she showed us in the PET scan of a neglected brain and a healthy brain. How inactive a neglected brain, that actually was taken from children who were orphans during Ceausescu in Romania, who were fed and clothed but no interaction. They are emotionally neglected. And these children, the part of their brain that deal with emotions and behavior and processing, as Professor Afaf showed us the very striking picture, as inactive. Then you go to your hand function coordination, then processing these. So you are taking everything and you are processing what you are hearing, auditory processing, visual spatial perception, which we know it's very important, your executive function, that's important, your academic learning, attention control, which is very important, your academic learning. So all of these things we find, for example, children with congenital heart disease who's been prolonged stay in hospitals, or children who have not had good interaction with their parents might have visual spatial perception, which actually impacting on their learning, especially mathematics and reading. And people think it's numerical a problem with numerical, but it's not, it's visual perception and attention. So you see how important the sensory is for the child learning to be intact. But these children, a lot of them have sensory difficulties. Sometimes they are misdiagnosed as autism. Not every child who has sensory problems has autism. I have seen a huge difference between the early 2000, when we started neurodevelopmental care, and after 20 years, how we don't get children with aversion to feeding in clinics now. How touch, they are touching different textures, how their parents actually don't have to put the washing machine on to get them to sleep, but because they are used to quiet time, it's not as toxic, the hearing, whether it's high or low. So it's hyper or lower sensory, increased sensory. And uh, and that's really has been impacted by developmental care in the unit. So how can developmental care help? You remember when I talked about proprioception and containment, organization? And that's what I see a lot in my clinic, is the lack of organizational skills, which I see now more in children in PICU who are not have had all the developmental care that neonatal units now in UK provide and all over the world. And I hope in all your hospitals, guys, that you have containment and the babies are not left out in space, where he doesn't know where he is. I used to get babies like this, and they used to, people think that they are cerebral palsy, and they were called dystonia of prematurity. If I ask any of my young colleagues now, the young consultants, have you ever heard of dystonia of prematurity? They say, what is dystonia of prematurity? So posture and organizational skills help the child to calm down, help the child to focus, help the child to have attention control, and then they can learn and feel secure. So they can build a relationship between them and the parents. The mother is not mentally disturbed, very upset and negatively impacted by the constant cry and disturbance. Every time you move the child, he just startle and cry, and he has postural stability. He knows his right and left. And you learn by bringing your hands together, not your hands up here in the air. So it's so important. And first thing we look at as well, around 6 to 8 months of age, is coming to midline, is be aware of your midline as well. So all of these things come through your postural stability. So how can you help me in the neonatal unit or in PICU or in a hospital, even if I'm staying only a week? Respect noise and light level, swaddle and position, age appropriate handling, and kangaroo care. So you have to understand the baby to know how to provide this. Massage, pleasant touch, the parents will provide this, not the doctor. So parents has to be there. Non-nutritive sucking is very important, where we give a baby a dummy during tube feeding. Why? It helps them organize themselves, and filling their stomach will help them to associate feeding with something pleasant instead of everything around their mouth is tubes are stuck in, or mouthwash or suction, so that they become so negative around the mouth. And we take mother's milk, put it on a swab, and give it to the baby, or give a goose swab between the baby and the mother, so the baby has the scent of the mother to calm them down. And we'll talk about the state of arousal. It's important that you respect the baby's sleep and work with their state of arousal. And from 32 weeks gestation, they have organized state of arousal and pain relief. And Professor Hafaf talked about the problem with pain, and we have to think clearly about pain relief. So um, we talked about the problem with the sensory difficulty and all the sensory stressors the babies can be under. And if you think about babies at home, they can be under these stressors when family have television on 24 hours a day, when people don't respect babies at home who are sleeping, when they wake them suddenly or constantly, or they constantly stimulate them by shuggling them, or shuggling, that's a Scottish word, sorry, by shaking them, or moving them, putting them on the move all the time. So how are we handling babies? That's very important to think about. Do you know a baby in intensive care will have 16 procedures a day? And stress and pain can cause the same impact on the brain development. So we have to be aware of this. Inadequate treated pain occurring during critical window of increased plasticity, which Professor Affaf has told us all about the plasticity of the brain, will affect the neuronal synaptic organization and contribute to the development of chronic pain. So these babies have either chronic pain or wind up reaction to pain, where or non-painful stimuli. So it's say they found sometimes babies who are circumcised without any pain control, they will react to certain non-noxious stimuli as if it's pain. So think what we are doing, and when you are doing a blood test, is not just the task of doing a blood test, is that looking at the baby and thinking about that this baby actually feels pain. Till actually um, 2000, 2005, some nurses even thought that babies don't feel pain. Some parents ask if they feel pain. Some parents still come and say, oh, I might do the circumcision early before they feel pain. Baby's pain synaptic connection is ready from 24 weeks gestation, and they have myelination of the peripheral pathway from 30 weeks. Even myelination will continue. They actually, even the nerves that suppress the impact of pain are less myelinated. So there is heightening to the pain response in the babies than actually an adult. Adverse effect of pain on the nervous system of the newborn. Immediate harmful effect of pain, the babies will become very unstable, and they might have even changes in blood pressure, which can impact on the brain by giving intraventricular hemorrhage. And painful stressors can lead to sleep disturbance, feeding problems, and inability to self-regulate. And that's what I was talking about, self-regulation. Repetitive pain in a preterm baby may be associated with attention difficulty, learning disorder, behavioral problems in later childhood. So you have to think, how can I reduce the impact of pain? It could be the mother carrying the baby, or soothing the baby, or talking to the baby. And I tell you that it makes a big difference. I sometimes ask the mother to be with the baby when I'm doing blood tests, when I used to put cannulas in, especially if it's a difficult one. The baby is much calmer. Or the mother smell, or if I look and I find the baby quite anxious, I ask the mother to speak immediately to the baby to calm the baby down. And it empowers the mother when she feels that, oh, my baby quietened to my voice. And we give before any heel prick or procedure or IV cannula or bloods, we give breast milk drops because a baby's sweet taste buds develop first, so they have a preference to sweet taste, and that's why the breast milk is sweet and it soothes them, and because it has as well the scent of the mother. And babies know the scent of the mother because even from 14 weeks in the womb, the chemoreceptors are actually developing in amniotic fluid specific to this pregnancy. If not available, we give a drop of sucrose. Think about local anesthetic if you are doing a procedure and analgesia if required for chest drains or etc. We heard a lot about toxic stress. So we know that there is sensory impact on the child. We know there are babies with us in hospitals they can be exposed to a lot of pain. To a lesser degree, babies at home can be having sensory overload and they can have a pain without pain control if they are requiring a lot of procedures. And then toxic stress. Toxic stress can be on the mother and on the child. And if it's on the mother, it will impact on both. And they found in adults, toxic stress is when I am worried about my baby and I'm worried about the finances and where am I getting the treatment. How can I cope with the treatment, with the jobs? You find that in a poorer area, deprivation, toxic stress can be higher. And if you are younger, mothers can be. And we know that one of the higher risk for preterm delivery is poor nutrition, is young age. And of course, we know that multiple pregnancies is one of the highest risk. You get about 65% of multiple pregnancy born preterm, while it's about in UK about 6.8% for singleton. That's up from 5.2. So toxic stress, you can, as we talked about, positive stress, and maybe it can be life saving even if I my adrenaline works on my muscle, allow my muscles to produce allow me to run from a car going to hit me, etc. And then we have the tolerable stress. The toxic stress is prolonged activation of stress response in the absence of a protective relationship. And that's what I want to concentrate on, the absence of a buffer that reabsorb this cortisol level, so it doesn't have the negative impact that Professor Afaf was telling us about. So you will produce chronic stress hormones, but you need it to be reabsorbed. They even find that it's not only affecting the brain, it can affect the immune system and the respiratory system. And that's what I was saying about how does it impact on a child, toxic stress. Of course, abuse causes toxic stress, unpredictability causes toxic stress, as Professor Afaf was just telling us. And it can put the children in fight or flight, anxious. And the babies, you see them, they are startling. You come near a baby, watch their eyes, guys. They will look frightened, they will look scared. They are having short attention span. They cannot concentrate for long period. They struggle to learn, and they react to the world as a constant threat, and they don't trust other adults, and they can't. When they get older, they cannot perform healthier relationship, and they always feel failure, despair, shame, and frustration. That's why I want you to look at the baby, because we need to act upon this stress in the beginning, because I told you that stress and pain can impact physiologically on the child, and Professor Afef told us that long term it will impact on the child brain. But do you know what? The first thing is your clinical changes. So the baby's behavior is his language. And if you learn to look at the babies, you will learn the signs of what makes them stressed and what makes them comfortable. And they are individuals. And that's what I encourage the mothers every time I see a baby in intensive care or PICU or cardiology wards or in the children's hospital. I encourage the mother to know her baby. I show her the signs of stress, signs of relaxation, and she has to be capable of reading her baby. And it's our responsibility to make sure that these babies are right. So, what do you think this baby is saying? So, if I'm interactive with you, I would have loved to hear. So, it's saying, so spreading the fingers like this is a sign of stress. I see it a lot in their toes as well. Their toes go up and very stressed. Yawning is a sign of stress. Positing, bringing up a bit of milk, is a sign of stress. Crying, if they are older, you will see them crying and frowning and and arching their back and doing this. Preterm baby might yawn. I see term babies do hiccup. Sneezing is not a sign of stress, it's a reflex, but hiccup, positing, yawning, fanning their fingers or their toes and arching their back and frowning. And then they look away when they had enough. It's called gaze aversion. These are signs of stress in babies. As I said, we have to work with the baby states of arousal. So babies have 6 states of arousal. They go from deep sleep to light sleep. And this is very important because during light sleep or REM sleep, they lay down a lot of their visual retinal ganglion cells. So it's important for growth and for visual maturation. And then they become drowsy, then quiet alert. That's the best time to interact with the baby. So if a baby is crying, because after that they will go into fussy and then distressed and crying. If you want to do a procedure with a baby who's crying, or mother want to tell them a story, it will not work. If a baby is fast asleep and you start pricking them, they will be very, very startly and it's not good for them. So if you want to interact with the baby and you have no way of coming back to this baby, you have to do it now. Try to get them in the quiet alert. And from 32 weeks gestation, babies can maintain a quiet alert for a short period. So it's very important. So we always talk about cluster care. What does it mean? I think if you are working in a unit, think about what am I going to do? Think about the procedure. Do I have to do it now? Or can somebody else, you can, while I'm examining them, I will do the bloods, or I have to go in and interrupt the child every 5 minutes. And I have to come with a huge group to teach, and the baby is fast asleep, and I will wake him up to do this and do that. So we do something called cluster care, which means concentrating the care of the baby in a cluster so we can give them periods of rest and try to, as I mentioned, bring them to a state of quiet alert. Don't wake them up suddenly with cold hand. Look in their eyes. If they look scared, they respond so well to your voice. Quieten them. I hope the mother is there so she can calm them down. We heard a lot about the limbic system. I'm not going to talk about it because Professor Afaf adequately and very and excellently talked about the limbic system. But I just want to say that the limbic system improve during attachment behavior. So you need the mother to improve the dendritic arborization, which happens very rapid in the first 3 years of life during attachment behavior. So you need the mother. And as I mentioned before, it's use it or lose it. If you are missing part of the early neurobiology of attachment, you might lose a lot out. And that's why babies actually who have prolonged maternal postnatal depression and unrecognized and untreated, I see them later on coming to the clinic and behaving like children with autism actually. And sometimes they improve as the mother mental health improve, but sometimes the damage doesn't go away. I'm not saying this is causing autism, but they behave like it. And the same, children who are born preterm and stayed for months in hospital, or born with severe congenital heart disease and they had to be in and out of hospital, they can behave like children with autism, but they are different. There is a difference between them and children with autism. And I'm not going to go into this because Professor Afaf has talked about it and the importance of the limbic system that matures during your attachment behavior, and the impact of stress on it and its importance in learning. That's why there is a huge role for parents. So please allow the parents in the units. Allow encourage the mother not to come and socialize with others, although it's important for her mental health, but she's there to care for her baby. And the same with the father, whether it's skin to skin, reading to them, just touching them. I love this. Synaptic connection is growing through love. So empower parents, because empowering parents will improve outcome. The preterm birth in UK is 1 in 8%. So statistics say I am 1 in 8, but my parents tell me I am 1 in 1 million. So every baby we are seeing is a baby of a parent, and this baby is going to have his life ahead of him, and it's our honesty and responsibility to be honest with these babies. I know the stress we are under, and I know as doctors how much pressure we are at home, in the hospital, in our clinics. But sometimes it's just, I always have to take a step back and think. But it's so easily done that you just revert back to having to do your job and nothing more. But just in just take a time if you find the baby is so scared and so worried to calm them down before you do your procedure or examination. These are some of the references, and thank you very much for listening.